Welcome to the podcast Leger om livet, or Doctors on Life as it's called in English. My name is Annette Dragland. I'm a medical doctor, and my intention with this podcast is to make useful, fun, and important knowledge about body, health, and mind easily accessible to us all. Today, I'm so happy to welcome Dr. Louise Newson to the podcast. Dr. Newson is a GP and Menopause Specialist whose passion is deeply rooted in advocating for improved menopause care and education, addressing the crucial need for accessible evidence-based treatment options for women navigating perimenopause and menopause. In 2018, she founded the Newson Health Group, which was established to be the center of excellence, providing evidence-based information, support, and treatments to perimenopausal and menopausal women. Beyond her clinical achievements, Dr. Newson has developed the acclaimed Balanced Menopause Support app and website, providing indispensable resources for women worldwide. Her influence extends into the digital sphere with Dr. Louise Newson podcast, celebrated as the UK's top medical podcast. As an author, her contribution includes the notable Preparing for the Perimenopause and Menopause, a Sunday Times #1 bestseller, and her latest publication, The Definite Guide to the Perimenopause and Menopause, which further her commitment to providing valuable insights into menopause care. Welcome, Dr. Louise Newson.
Thank you. Thank you for inviting me.
I'm so happy to have you here in Norway. How's your stay?
Oh, do you know, it's really exciting. I've never been to Oslo before. We came to Norway the first time last year with my family because my husband's great uncle was Ola Bull, actually.
Oh.
So we have some connection. And my grandmother was Norwegian. She grew up in Lillehammer and came over when she was 18 and met my grandfather. So we've both got Norwegian blood in us, but I've only been to Norway once before. So it's great to be here.
Wow. So then you have to come more frequently to Norway, and you have to spread your knowledge.
Yeah.
Because you are one of the best in the world on this subject. It's so important what you are speaking about, and we will go into it quickly. But today we're talking about perimenopause and menopause. But could you please explain the difference between those two?
Yeah, absolutely, because we use the words a lot and there's still a misunderstanding. Actually, last night, as you know, I was talking to over 500 lovely Norwegian women and some men, and I asked the room whether they were confident in explaining what the menopause was, and only about 5 people put their hands up. Yet they'd come to a presentation knowing it was about the menopause. And actually, when you look at it medically, we're told it's menopause, so meno being the menstrual cycle, the woman's periods, and pause is a stop. So the definition is a year since the last menstrual period. But I have a real issue, actually, with that definition because, as you know, as a doctor, we don't make a diagnosis in retrospect. We don't say to a woman, oh, come back in a year's time and then I'll give you a diagnosis. If someone's in front of you struggling with symptoms, what are you going to do? Are you going to wait? Of course you're not. And how does that definition occur? Like, what's different a year after your period stopped to a year and a day or 11 months? I think it was just made by probably men around a boardroom who never speak to women. I don't know. It doesn't make sense. So then actually a lot of people say, well, it's associated with loss of fertility. So they call the menopause our post-reproductive life. But actually, I don't want to be defined by my fertility either. And for many cultures, it's not actually it's quite a taboo to talk about whether you're fertile or not. And also, as you know, many people are young and have an early menopause. And those women, if they have treatment with hormones, can actually improve their fertility. So I think it's really wrong to talk about fertility with menopause. So then we should think, well, what is it? What happens? And what happens is that our ovaries have a finite number of eggs. When the number declines, the hormones that our ovaries produce decline. And we're only talking about 3 hormones: estrogen, progesterone, testosterone. They're sometimes referred to as our sex hormones, but they're not actually all about sex. They're not even all about gender, because men produce these hormones as well. But they're 3 hormones that cause a lot of confusion and angst between all sorts of people. But our ovaries produce them, but other areas in our body produce them as well. So our brain produces the hormones, our adrenal glands, our muscles, even our heart produces estrogen. But when we don't have our ovaries working as well, those levels of hormones decline. And so when the hormones decline, that's when people become menopausal. And so the hormones are low forever. but they usually don't stop straight away unless someone obviously has their ovaries removed. Usually what happens is as we age, our hormones decline, but in a very chaotic way. So they might be up one day, down another day. So there's this chaos happening in our brains before the hormones plummet. And that time is called the peri-menopause. And as you know, peri just means around the time of, when medically when you translate it. So it means around the time of the menopause, but that can occur for several years, sometimes a decade before periods stop. So women are still having periods. They might be lighter, they might be farther apart, but they might be heavier and closer together, or they might be regular, but they're getting all these symptoms. Because our hormones, as you know, are just chemical messengers. They go into our bloodstream, they go all around our body, they go to every single cell in our body. And these hormones, estrogen, progesterone and testosterone, affect every cell function in our body. So when the levels are changing and when the levels are low, we can get a myriad of symptoms, but we can also have health consequences as well. So it's not something that we should just think, oh, well, it's just something we have to have as a woman. Of course, every single woman will become menopausal and it will affect us in different ways. But once we understand what it is and how our bodies are changing, that's when we can think about what can we do about it and what treatment options are.
So the perimenopause, many women don't understand what they're going through. And when you say it's chaos in the body, the hormones go up and they go down. It's not easy to understand what's happening. And I get that a lot in my office as well, that my patients say that they went maybe 5 to 7 years before they understood that it was perimenopause or their menopause that was happening to their body. Could you please explain to us what are the symptoms? Because it's quite a lot.
There's so many symptoms, actually. There's hundreds of different symptoms because, you know, if you just think about estrogen, it's involved in over 1,000 cell processes in our body, and it can affect every organ in our body. So a lot of people think that the menopause is about hot flushes and sweats. And hot flushes and sweats can occur in many women, but they're not the symptoms that are really affecting women the most. So when we've got this Free Balance app, as you know, and when we've looked at people who have monitored symptoms across the world, the commonest symptoms are the symptoms affecting our brain. So there's low mood, anxiety, poor sleep, memory problems, this brain fog, this inability to think clearly is a really common symptom. Reduced libido is very common. Muscle and joint pains, palpitations, headaches, vaginal dryness, urinary symptoms, itchy skin, dry skin, hair changes. It can go on, but not everybody gets every symptom. And so on the Balance app and on our website, we've got a common symptom questionnaire that we use in all our patients as well. And that's useful for people to do every few months just to see if they're getting any of those symptoms. But I've seen some people with just literally one symptom. I saw a lady a couple of weeks ago who had a lot of tinnitus, this ringing in the ears. She'd seen ear specialists, she'd been told it was normal, it was keeping her awake at night. She'd stopped working because it was so distracting. But she was also 52, so I knew she was menopausal as well. Her periods had stopped. So giving her back hormones, I'm sure will improve her tinnitus because we see it a lot in the clinic. So people think you have to have a certain number of symptoms or a certain duration of symptoms to have that diagnosis, and you don't. And it's very difficult because there isn't an easy blood test or a urine test or a saliva test that's going to diagnose it. But actually there are clues because, as you know, when women are having their normal regular periods, our hormone levels are changing all the time. And we have a peak of our hormone levels when we ovulate in the middle of our cycle. And then the second half of our cycle, our hormone levels decline. And just before our periods, our hormone levels, especially estrogen and progesterone, are very low. And a lot of people get a flavour of what the menopause is like on those days. So when you really ask patients and women, how do you feel just before your period when you were younger? And they'll often say, yes, I felt really irritable, I felt really flat, I had sugar cravings, all I wanted to do was sit down and eat chocolate. And now I'm feeling like that, but it's not just a day or two, it's happening more frequently. And so often women do know, but they don't always put it together And there are a lot of women who think that they've just stressed because of work, or they've got busy at home, or they've been misdiagnosed with depression. So it's really important, I think, as women, that we take control ourselves and get the education and start to monitor symptoms, because then we can try and work out, could some of this be related to our hormones?
But just hearing you talk about all these symptoms, it's profound how much these hormones affect us and how important they are to us.
Yeah.
And when you say even tinnitus, you say brain fog. Do we know how we can get brain fog from low estrogen?
Yeah, actually we've known for many years. So I've got a pathology degree as well, so I'm quite interested in science. And the role of our immune system is key, as you know, to everything. So if you look at our immune cells, our cells that fight infection, we've got receptors to estrogen on them and our other two hormones, progesterone and testosterone. And if we've got good levels of estrogen, then our immune cells work well. The estrogen can genetically reprogram these cells, it can increase the number of the cells, it can change the chemicals, the cytokines that are produced by those cells. If we have low levels, our inflammatory system changes, so the immune cells become pro-inflammatory. So they change the number, they change the action, the way that they work. If we've got low-grade inflammation in our body, that obviously can cause diseases, and there's obviously increased risk of diseases in the menopause. But also there are receptors in other areas. So if you think of tinnitus, for example, our nerves change when we don't have hormones there. So if we have hormones, our myelin, the myelin sheath that conducts all the nerve pathways, can regenerate with hormones. Also, it can help improve the way that the neurons grow and function, and they work as neurotransmitters, so the chemicals that tell one nerve to another how to work, these hormones all work, and they also balance other neurotransmitters in the brain. So it's all very basic physiology that we should all be learning at medical school, because, you know, we've got books and papers from decades ago telling us that. And this is about our natural hormones that we produce. And when you look, even the way they're produced in the brain is really interesting. And so if someone had like a stroke or a bleed to the brain, one of the first things that the brain does is produce progesterone, because it's very anti-inflammatory. It repairs cells, it repairs damaged cells in the brain, because our bodies are so clever, aren't they? So we know all this. And so therefore, if you think, well, what would it be like without those hormones? Of course it's going to affect brain function. We know that estrogen helps improve the sugar, the glucose metabolism in the brain. It helps the way our mitochondria work, which is, as you know, the powerhouse of our cells. It helps reduce oxidative stress. So there's really important cellular mechanisms that are going on, but also there are genetic changes that can occur as well. So that's with the benefits of having estrogen. So it doesn't take much to understand that without estrogen, it's just not working as well. It's like trying to run your car without oil. You know, it's just spluttering. It's just not going to work as efficiently.
But what I don't understand is, why do women have to go through this phase then?
Well, if you think evolutionary, we shouldn't. So we are designed to reproduce. So we're designed to be pregnant a lot of our reproductive life. And actually, when we are pregnant, our levels of estrogen are very high. They're about 65,000, whereas they're about, well, between 250 and 1,000 when people are menstruating. So we have very high levels of estrogen when we're pregnant. Many of us feel great when we're pregnant as well, by the way. But then actually, then at the end of our reproductive life is usually when we should expire. And if you think in the Victorian times, the average age of the menopause was about 57, so older than it is now. And the average age of death was 59, so just 2 years later. We're living longer because of advances in medicine, of course. So there aren't many other animals that go through this menopause. So it's one of those things that we don't know, but there's lots of people that have other conditions as we age. So raised blood pressure occurs as we get older. People are more likely to have hypertension. It's not so much a disease, but it's a marker for future health. And it's no different with the menopause, really. We have these health risks, but what's happened is that people have seen it as just a marker of symptoms. So when they discovered estrogen many years ago, it was associated with hot flushes. But when they discovered thyroxine, it was associated with hypothyroidism, a condition. And when they discovered insulin, it was associated with diabetes, a disease. And so it's the perceptions of what the hormones are. And it's been ignored for so long also because it's a women's problem. So why should we bother about women? Surely it's all in our head. And I think it's very interesting if you look at the history of medicine, and I'm sure you know as well, but if you even think about the word hist, which is actually the Greek word for womb, and hysterectomy obviously is removal of the womb. But then we have the word hysteria. And so there are a lot of women, even now, who are sectioned, they're in mental asylums because of this hysteria. But actually a lot of women, when you tease it back, it started when their periods were changing or stopped, or they had their ovaries removed and something happened in their body. And I hear it all the time in the clinic. Yet people say, oh no, it's in your head, it can't be related to your hormones. Why can it not be related to our hormones? Of course, because our hormones are so powerful in our brains.
And we know that at least in Norway, the suicide rates for women is highest during this phase.
Yeah, and it's the same in the UK as well. And I had no idea till I opened my clinic, because I see so many women who have been under psychiatrists and mental health teams and crisis teams, and they're on antidepressants, they're on antipsychotics, they're on lithium, they've had ECT. Recently I've seen some people who've been given ketamine infusions. They're women in their 40s who have had PMS, PMDD, postnatal depression. Their periods have started changing, but no one has talked to them about hormones. It just doesn't make sense to me.
Yeah, that's why your work is so important. And when we know that it can have such profound negative ramifications, we have to talk about this more openly, because there is solutions and we can have a good life in our late 40s, 50s, 60s, 70s.
Yeah, for sure. And it's so important because it has been this taboo. People still don't talk. And I think as women, we're used to suffering. We're used to struggling with things, and we just get on with it. And obviously, I don't want people to think that everyone's going to get these awful symptoms, because a lot of people don't. But actually, even if we forget about symptoms and we forget about the suffering, I've already said there are health consequences of not having hormones. So menopausal women, whether they have symptoms or not, have an increased risk of all the inflammatory conditions. So they have an increased risk of heart disease, osteoporosis, diabetes, clinical depression, dementia. These are all really, really common conditions when you look at global health. The most common cause of death in women is cardiovascular disease and dementia. So we know that menopausal women, especially when they're younger and have a longer time without their hormones, have a greater risk of these diseases. Yet replacing those hormones will reduce the risk of those diseases. And it's a bit like comparing, like I said, to raised blood pressure. We treat it to reduce the risk of heart disease. So with the menopause, there's a greater risk of developing heart disease than there is if you've got raised blood pressure. Yet we don't see it like that.
Wow.
We just see it as it's a natural process women go through. And so I think we need to be really waking up to that fact, because it is fact. I'm not just making this up. This is just fact from... And when you understand how biologically active our hormones are and how they act in our brain, but also our cardiovascular system as well, then it's no surprise. It just makes sense.
But how many women actually get do we know the statistics of how many women struggle during this phase?
It's really difficult because a lot of the studies are quite old. But even when you look at some of the studies, about 75% of women about 75% of women have symptoms, and about 25% have severe symptoms. There was a recent study that said, it's not as high as that. It's only about 18% of women have symptoms. I don't care whether it's 90% or 2%. Women should not be receiving, or they should not be having symptoms if there's an evidence-based treatment that they should receive.
Exactly.
And a lot of women will misreport their symptoms or underreport their symptoms or not associate their symptoms related to their hormones. Something like flushes and sweats is very easy because there's very few things, as you know, in medicine. There are some conditions, but very few that cause flushes and sweats. But there's lots that can cause fatigue.
Yeah.
So we do a lot of work with an organisation helping people with lupus. And one of the commonest symptoms of lupus is fatigue. Well, how many of those women will be menopausal as well? You know, we just don't know, because you won't know how many of your symptoms are related until you have treatment.
Yeah.
And that's the problem, because so few women are receiving treatment.
So just to go through, you mentioned estrogen, progesterone, and testosterone. Do all of these three decline during menopause?
So it's very interesting, actually. Yes to estrogen and progesterone. Testosterone is actually the most biologically active hormone that we have as women, and we produce more testosterone than estrogen when we're young. But the levels of testosterone usually decline with age. So it's not a menopause-related hormone, really. It's just an age-related hormone. Because about half of our testosterone is produced in our ovaries, if people have a failure in their ovarian function, or they have their ovaries removed, then their testosterone will then plummet more quickly.
Yeah. Okay. So you see that testosterone decline also can affect us women?
Yes, definitely. And that's something that's been really underreported and under-recognised, because even if you think of the word testosterone related to testes, well, we don't have testes, do we? But actually it's produced from our ovary. A lot of people think that estrogen and progesterone is female hormones and testosterone is a male hormone. But as you know, they all come from cholesterol, and then the sort of pathway is cholesterol, then there's progesterone, then there's estrogen, then there's testosterone. But actually men produce progesterone and men produce estrogen as well, which can really play with people's minds when you think about it.
Yeah.
You know, a menopausal woman has less estrogen than her husband probably in their bodies. But we always just focus on estrogen for women. Progesterone is often thought of just if we've got a womb, we need to take progesterone, and it's a very important hormone. And then testosterone as well is always just thought of, oh, it's just for men, or more recently it's been thought of it can just help libido in women. But again, we have testosterone receptors all around our body.
Yeah.
We have them in our heart, in our lungs, in our GI tract, especially in our brain. Testosterone works as a neurotransmitter as well. So we can't ignore the biological effects of testosterone in our body.
So going through this, it sounds like a difficult phase for very many women, and we know here in Norway, in England, you're better at getting help. In Norway, I don't remember the numbers, but there's very, very few percent in Norway that get treatment for their menopause because of all the scary side effects we've heard about. Could you please tell us, is a hormone replacement therapy safe, and what is actually the side effects? Because I think a lot of women worry about this.
Absolutely, and it's not just in Norway, worldwide. Even in the UK, everyone thinks that we're doing really well. HRT prescribing is still really low. So in the UK, about 14% of menopausal women receive HRT. Globally, it's about 5% of women. Yet the guidelines, the evidence are very clear that it is treatment that has more benefits than risks, and it's first-line evidence-based treatment for the majority of women. So the majority is not 5% or 14%.
Yeah.
But if you say to women HRT or healthcare professionals HRT, the first thing that they'll come up with is breast cancer.
Yes.
So I'm happy to demystify that. And it stems from this study, which it was just so sad it ever happened, really. It was called the Women's Health Initiative Study, the WHI study, and it was brought out in 2002. Yeah. So in the 90s, when I started, I qualified in 1994, and we were prescribed HRT a lot. It was given out to people because we knew it helped people feel better. Actually, in medicine, that's a good thing, to help people feel better. But more importantly, we knew that it was helping strengthen bones. We knew there was a reduced risk of heart disease. People would really wake up to the fact how important our hormones are. So we used to prescribe it a lot. And then they decided to do a study looking at, wow, I wonder if it's going to be as helpful starting it in women who are older. And it was $1 billion study. And that in itself is quite remarkable, because since that time, there hasn't been $1 billion spent on women's health research, as you know, or hormonal research, which is so awful. So anyway, they did this study. They were looking at the effects of HRT in older women. Now, there's a couple of things that's really important about this study, and one is the type of HRT. So HRT just stands for hormone replacement therapy. which actually it's not really, because it's only about these sex hormones. It's not all hormones, but there are different types. So in this WHI study, they use very synthetic hormones. So the estrogen was a tablet, and it was derived from pregnant horses' urine, which you could argue is natural, but it's not something we really want to take. And we know that tablet estrogen does have some effects because it gets metabolized in the liver. So there's a risk of clot, and there's a risk of stroke with it as well. And then they also, those women that had a womb, they gave a synthetic progesterone called medroxyprogesterone acetate. We know it doesn't work in the same way as our natural progesterone because it's chemically altered. So it has a small clot risk, it has a small heart disease risk. We know that. So they gave women, and the average age of women in this study was 64. And these were women that hadn't been on HRT. So they gave women this type of HRT and followed them up. They started to notice that some women seemed to have an increased incidence of breast cancer. And as you know, in a big study, what you do is you analyse results really carefully and you reanalyse them, and you get the best statisticians and go through the results. But they'd seen this result and they hadn't analysed them properly, but they'd told the newspapers and they'd told the New England Medical Journal. And one of the investigators, Rob Langer, I've had him on my podcast before, said, a group of them said, please don't publish this data because we haven't looked at it properly. They said, it's too late, it's gone to the press. And if you look at footage from that time, there's people sitting on sofas being interviewed in the press saying HRT causes breast cancer. And of course, I understand completely. People stopped prescribing it overnight.
Yeah.
It was a massive car crash, but actually it's been the biggest travesty to women's health ever. Because since HRT prescribing has reduced, the incidence of heart disease, especially in women, especially in America, has really escalated. Women's health has just deteriorated, and suffering for women has actually escalated as well. But they've reanalyzed the data. They've looked at it properly. We've now got over 20 years data, obviously, because it came out in 2002. And there's some really reassuring parts of it. So firstly, when they look at the women who were only taking estrogen, who'd had a hysterectomy, those women were shown to have a 23% lower incidence of breast cancer. So the estrogen, which is no surprise because it's so anti-inflammatory, isn't associated with this increased risk of breast cancer. The breast cancer risk was associated with women taking the estrogen with the synthetic progesterone, but actually it wasn't statistically significant anyway. And the study wasn't set up to have breast cancer as a primary endpoint. It was looking at cardiovascular disease as a primary endpoint. So if you look at the way the study was designed, it wasn't designed to pick this up anyway. So there's lots of flaws in the study and the analysis, but actually also the other reassuring thing about it was that any type of HRT, if someone did develop breast cancer, their prognosis, their outlook, was actually better than compared to someone that had never taken HRT. But, and this is a big but, we don't prescribe those types of HRT. We now prescribe the very natural, body-identical hormones that are derived from yam plants. So it's like comparing apples and pears. They are very different. So we now just use the natural hormones. So if I look down the microscope, they are exactly the same as the hormones that we produce when we're younger. So they have the same biologically active processes and benefits that I explained earlier. Whereas the synthetic hormones don't have the same results, and they're more pro-inflammatory. So they're not going to have the health benefits anyway.
So that's what you call the bio-identical?
Well, we call them sort of body-identical. There can be confusion with the term because some people prescribe these bio-identical hormones that are compounded, so they're not regulated products. And as you know, if something's not regulated, it's not consistent with the way that it's produced. So we always prescribe the regulated products. They're not always licensed, because, for example, testosterone isn't licensed for women in the UK or in many other countries as well. But it's still the regulated product, and that is important. But they are exactly the same as the actual hormones that we produce when we're younger.
Okay. So can you go through if a woman now wants to try treatment for her menopause symptoms, what would she get then?
Yeah, so we know from the evidence that the earlier a woman takes hormones, the better. So that's really important, that they can be started in the peri-menopause when symptoms start. We don't have to wait until we're menopausal. And like I say, the peri-menopause can last many years. So you don't want many years of suffering. We also know that the sooner a woman takes HRT, the better for her future health. So we know that women who take HRT have a lower risk of heart disease by about 50%, and a lower risk of osteoporosis, and also a lower risk of dementia as well when it's the body identical hormones that are taken. So it's not just about waiting for symptoms for a certain length of time, for example. So usually in the clinic what we do is we start estrogen and progesterone if people need progesterone, and then review them. And then the guidelines say that if women have reduced sexual desire despite being on HRT, we can consider testosterone.
Okay.
And so we then, if women want to try testosterone, then we try testosterone and then review them and do their blood test to make sure it's in the female range. But we do find, and many other clinics notice the same, that women find that their mood, energy, concentration, stamina, their sleep, often their headaches, muscle and joint pains really improve with testosterone as well.
Okay, so all three?
Often, yes, yeah. And then there's also vaginal hormones as well, which are different to HRT because they only work in the vagina and the surrounding tissues. So whether a woman takes HRT or not, they can be really, really useful for people with localized symptoms, so vaginal pain, discomfort, and urinary symptoms as well. So people find that they go into the toilet more frequently, they might have some urge, they might have some incontinence, and also urinary tract infections and cystitis. So they can be really beneficial for those women too.
People who are against this, they often say, but every woman goes through menopause. It's a natural phase, or why should we medicate something that's natural? What do you have to say to that?
Yeah, isn't it interesting? So I don't really see it as medication because it's just natural hormones. There's a lot of people that have underactive thyroid gland, and of course they can survive without their thyroid gland. They'll feel more tired, they'll probably put on weight, but they can continue without thyroxine. But a lot of people take thyroxine because it helps the body to function better. And then you think of other sort of natural things. So being in pain in childbirth is natural, but we give painkillers for it. You know, so we need to sort of think about what do we mean by natural? Then a lot of people say, well, I'm going to take a natural supplement for my menopause. And there are some supplements, obviously they're not regulated. There was an article in the paper recently of a lady who had liver failure because she'd taken a black cohosh, a supplement, to try and help her flushes, and it affected the liver. There's lots of plants in my garden that are natural, but I wouldn't want to eat them.
Yeah, exactly.
So we just have to be careful. And I think the other thing to sort of let us think about is, what are the risks of not taking hormone replacement? I'm not here saying everyone has to take it. I'm saying everyone should know about it. So if I, as a menopausal woman, which indeed I am, wasn't taking HRT, I know that the symptoms I had would have stopped me working because my brain had gone, my memory had gone. I was also getting a lot of migraines. I was finding working as a doctor really difficult. So if I wasn't taking HRT, I probably would still have some symptoms. I don't know whether I would have them all, but that's something that concerns me. But actually, one of the things that concerns me even more is osteoporosis. I've seen a lot of women with osteoporosis of their spine who have had a lot of pain from these microfractures they get. It's very difficult to digest food, very difficult to be mobile. I don't want osteoporosis. So one of the reasons I take HRT, it's a personal decision, is to reduce my risk of osteoporosis as well as other conditions as well. If I didn't take HRT, I know I've got an increased risk. So of course I can look at my nutrition, which I do. I can look at my exercise, which I do. I can look at my mental health and well-being, which I do. But I can't replace those missing hormones. There's nothing else I can do to have those hormones back.
So you can't eat yourself out of it.
You can't eat yourself out, no.
But are there any lifestyle factors that can influence it and make it easier for us?
Yeah, it's really interesting because, yes, of course. And actually, as a GP, I'm really holistic in my care. Not just my care for myself, but my care for patients. But I see and speak to so many women who have been told, come on, you need to exercise more, you need to eat better, you need to sleep better. And these poor women have been trying so hard, but when they're menopausal, it is a cardiometabolic problem. So it changes our metabolism. That's why there's an increased incidence of heart disease and diabetes, type 2 diabetes as well. people tend to put on weight when they're menopausal. Sometimes it's because they're comfort eating, they're not eating the same food, or they're just sitting around, they can't exercise because of the way they feel. But also, our body does need estrogen. So one of the ways it can produce estrogen is by increasing our number of fat cells. Now, our fat cells, our adipocytes, are very active. When I was at medical school in the 80s, we were just told it was just like an inert substance that didn't do anything. But of course, we know they're very active, the adipocytes. They do produce estrogen, but they produce estrone, not estradiol. And that's important because the commonest estrogen we produce when we're younger is estradiol, which is very anti-inflammatory. Estrone is the pro-inflammatory estrogen. So when people have estrogen as a tablet, it gets converted to estrone, which is pro-inflammatory, hence the problems with the WHI study. But also in our body, so when people are putting on weight, they're giving themselves more estrogen without realising. But actually it's not the best estrogen. And we know weight gain is not ideal. So women often are then made to feel more of a failure because they come and they say, I've tried everything and I can't lose weight. I can't sleep. I've been doing all this self-help. I've been meditating. I've been trying. But they're trying to do it without hormones. And often the hormones is the missing piece. So often when people have hormones, it's so much easier to have a better lifestyle. But if you only have hormones and smoke 20 a day, drink alcohol, don't look at your diet, then the hormones are good, but they're not going to help everything. So that's why it's looking at really, 360-degree care with the menopause, because the menopause lasts for decades. If the average age of the menopause is 51, the average age of death is 83 in the UK. That's 30 years. But 1 in 30 women under the age of 40 will have an early menopause. My youngest patient was 14 when she was diagnosed with menopause. So she's got the majority of her life being menopausal. So we can't just think, oh, it's nature's way, let's just enjoy it, let's just go see what happens, because it's not fair on our bodies.
So if you're on HRT and you want to change some lifestyle factors, what would you recommend then?
It's really important to not do everything at once, I think, because otherwise it's really hard. Nutrition is so important, and it's something that we should be looking at more and more, and it's probably easier in Norway than it is in England to eat healthily, but certainly there's so much processed foods. It's so easy to snack on rubbish. It's so easy to eat the wrong foods. So looking at processed foods is crucial, looking at our sugar content, even looking at what we drink. It's so easy. A lot of women say to me they drink more alcohol because it helps them numb their symptoms. It helps them forget about things.
Helps them sleep.
They think it helps them sleep, but obviously it doesn't. And then a lot of people will have fizzy drinks, they'll have fruit juices. All of that is actually not good. So looking at what we're drinking, looking at our gut microbe is really, really crucial, because then it all works together. And obviously looking at smoking, looking at exercise. Many people find their type of exercise has to change. You doing high intensity, like adrenaline inducing exercise increases cortisol. And we know that adrenaline and cortisol, those levels can change when our hormone levels are low. And so actually a lot of people find that they have more cortisol, then they find that they're not able to exercise as well, but also they tend to put on weight despite exercising. So sometimes people find doing different types of exercise like yoga or Pilates can actually be more mindful, but actually it can be more calming on the body as well. So because our body is adapting as we're aging as well, it's not always related to hormones, but we need to be sort of working out what's best for us, both physically and mentally.
So women experience that they get higher cortisol during their menopause. Many women do.
Often, yes, yeah.
Many women gain weight during this phase. I don't know, will they as well, if they are on hormone replacement therapy, will they increase in weight, most women?
No, actually a lot of women lose weight on HRT, and it's been quite muddled, because when people have looked at studies, they've looked at older types of HRT as well as the more natural body identical hormones. But actually, if you replace the missing estrogen, our body doesn't have to make fat cells in the same way, of course. And so people often find, especially the midline that they often put weight on, that can reduce. But also estrogen and testosterone can help build muscle as well, because it can help build muscle strength and tone. So a lot of people find that they're able to change the shape of their body more easily. When they exercise, they say that they can feel that their muscles coming back, they feel that their posture's changing. And that's really important. So it might not be their actual physical weight that changes, but actually the makeup of their body. And we know that this sort of visceral fat, the central fat, which is a marker of heart disease, as you know, and inflammation, that often can reduce as well. And it's getting the combination is right. And that's really important with HRT, is that there are different doses and there are different types.
Yeah.
About a third of women who come to our clinic are already on HRT, and some of them say, oh, it doesn't work for me. And then you look at what they're either on a really low dose or they're on the synthetic hormones, and then you convert them to the natural hormones and give them the right dose that's right for them, and they're completely different.
Okay, so it's important to get the right types of HRT as well. I just thought of a question that I probably will get from a lot of my listeners is, how do I know if I'm going through perimenopause or it's just a lot in work or life?
Yeah, and that happens a lot, and it's impossible to know. Yeah. And so one of the things we often do is just give a therapeutic trial. And it's the same with anything in medicine, but everyone seems more worried when it comes to hormones. So if I thought someone had... someone had migraine, for example, and I knew from the history they had a migraine. There's no blood test for migraine. We don't rush and do a scan for a migraine. It's all in the history. But if I think someone has migraine, there are first-line treatments that I try. If they come back after 3 months and say, no, my head's really bad, I've got more frequent migraines, I will talk about other treatments. It's exactly the same with the perimenopause. If a woman comes and says, I think some of my hormones are related, then I can say, all I can do is give you back your missing hormones in a physiological way, and let's see what symptoms are left. So a woman with a headache might also have a brain tumour. I don't know. Or someone with palpitations might have a heart condition. I don't know. But they can have both. They can also be perimenopausal and have a heart condition. We do it all the time in medicine. We're making diagnoses all the time when we talk to patients. And sometimes there are 2, 3, 4 different things going on. And we can address them all. But say, for example, someone with palpitations. I take a good history. I examine them and I think, well, there's nothing, a red flag. There's nothing serious that really means they have to go into hospital today for their palpitations. So they'll often have other symptoms as well, which I think may be related to their hormones. I'll prescribe them HRT. I might also refer them for a test to their heart. But usually what happens is their palpitations melt away before their appointment comes through for their heart investigations. And then the proof is in the pudding, really. You can see. But if the palpitations carried on or persisted or changed, of course they would need a cardiology. The problem is it's all happening the other way round. So we see hundreds of women that see cardiologists for their palpitations, they see neurologists for their headaches, they see rheumatologists for their muscle and joint pains, they see urologists for their bladder symptoms. They're on a myriad of treatments and no one has talked about hormones. So once they're on HRT, they often come off their antidepressants, they come off their painkillers, they can even reduce statins in their blood pressure treatment. So we're de-prescribing a lot of the time.
Oh, that's
so
great.
The menopause is being medicated with the wrong things. And that's really worrying, actually.
Are there any clues, though, for women who are in their 40s and thinking about it's if it is this or it's just
looking at symptoms. So downloading the Free Balance app I've been a medical writer for many years, so there's lots of information, lots of articles we're adding to all the time, so people can just read information, but also there's the ability to monitor symptoms as well. And it's worth people doing, even in their 30s or 20s if they think there are hormonal changes, doing it every 3 to 6 months, and then just having an internal check with yourself. Do you think any of these symptoms could be related to your hormones? And that's the biggest question that people need to ask themselves. And if women say yes, that's when they need to try and get some help, advice and treatment.
Great that you have this app. Okay, is there anything else that you want to share while you're here in Norway, and we're so lucky to have you here?
I just want people to have knowledge and make sure it's the right knowledge, because just being here for 24 hours, people are still very scared about hormones. Women and healthcare professionals still seem scared. But actually, what I love about Norwegians is that you're very thoughtful and you want to learn. You've got this appetite for knowledge. So I think it's a woman's duty, actually, to understand what's going on, but also people around them should understand as well. Because sometimes when you're menopausal or perimenopausal, it's overwhelming. And it's very difficult sometimes to learn new information. So we all should be having this conversation, but we shouldn't just be talking about the symptoms. We should be thinking about treatment as well. So I feel like there's a lot changing already globally, certainly in the UK, because women are understanding how important our hormones are. So I'm hoping me coming as a start of a conversation, but I really want it to continue as well.
Yeah, I know we are behind the UK, so I'm very happy that I get to share your knowledge with the more people in Norway. Thank you so much for joining the podcast.
Thank you for inviting me. It's been great.
And if my listeners want to find you, where can they find you?
So my website is drlouisenewson.co.uk, and then you can link on to the podcast or to the Balance app from that website. And I'm very active on my Instagram, which is menopause_doctor.
Great. I follow you. It's a great Instagram account. And if you have any questions for me, you find me on Dr. Annette Dragland on Instagram and Facebook. And I also recently got a YouTube channel, Dr. Annette. You can find me there, and please subscribe. And if there's anything else, just don't hesitate to reach out. And that's it for today. Have a great day. Bye.